Good morning, good afternoon, good evening, everybody. Thank you for joining us today for this global hand-in-hand webinar. The theme of this webinar series is really international collaboration with hand societies as well as international outreach. So today we have a very special webinar today that's focused on APPs and therapists that's entitled International Outreach in Challenging Environments for Hand Surgery. So I'm really excited to hear what our friends around the world have to say about this topic. And I'd like to invite Mary Barnes to moderate this webinar and introduce our panelists.
I'm so happy to introduce this distinguished panel of fearless and selfless humanitarians. Our first speaker is Dr. Oksana Myronica. She's a hand surgeon in Ukraine, and most of us can only imagine the challenges of providing care in a conflict zone. So, Dr. Myronica, thank you so much for joining us today.
Good evening from Ukraine. I'm Oksana Myronica. I'm hand surgeon and I'm working 20 years. Thanks for invitation for this event. It's an honor to represent you, our Ukrainian medicine during a war. Sorry for my English in advance. So I like to share you my presentation. It will be about treatment of hand injuries, what we have now when in Ukraine there is a hard war, terrible war. Our war lasts from 2014, and from the 2022 is full-scale invasion. So we really have a lot of patience. Okay. During this war, mostly we receive mine blast and shrapnel injuries, and they are often accompanied by thermal and chemical burns. Practically, we haven't received isolated hand injuries. Usually, it's injury of all body, all extremities, stomach, chest, head. So that's why these patients usually are very heavy, and even we hand surgeons during this war, we mostly very often we are working like common orthopedic surgeons or like surgeons in any area, not only in hand surgery, because our soldiers need in any surgical hands. And we have too much of wounded people. That's why our medical system is under heavy strain. Features of providing assistance to the wounded on the battlefield. Combat injuries are high energy traumas and that destroy all structures, bones, tendons, vessels, nerves, and soft tissues over large areas. This leads to tissue loss, to big defects for formation of massive scars and contractures. And if it's injury of heads, it's very hard injuries. Most injuries are complicated by infections that are multi-resistant to antibiotic. Why is it so? From the moment of injury to the start of first medical aid, it's after evacuation from battlefield. Several hours up to a lot of days may pass due to the nature of combat operation. Very hot bombing, and we just can't evacuate our soldiers, our wounded soldiers from battlefield. Medical care for the wounded is provided according to damage control system, and hand injuries are classified as non-critical, so specialized care is provided at the later stages of evacuation. It could be from a few days to several months. We received these patients in some months after injury with scars, with defects, with contractures, and it's really a big problem, and it's really difficult cases to treat. So it's a stem of stages of medical evacuation of from battlefield, military medical aid. There are some stages. First of it, it's medical aid on the battlefield by combat medics. Practically all combat medics now are working by new protocol, and on battlefield they apply tourniquets, dressing wounds. Sometimes it's self-aid, sometimes it can be help of his for another soldier, and as I told earlier, it's very difficult to evacuate wounded soldier from battlefield. Sometimes another soldier should carrying them of hands. Sometimes it's a new way of our medical aid. It's we use in ground robotic system for help people. So and sometimes it could be 1-2 hours from injury, but sometimes it's impossible to evacuate soldier, and we should wait. And soldier and we can wait it even some months, and all this time soldier is on a battlefield, and he is waiting sometime with tourniquets. So he received necrosis, and it's very difficult to treat in past period. But we're trying to save every one of our soldiers. Next step, it's stabilization point. It's a very small, all not hospital, but it's field, very, very small field hospital. Mostly now they are underground because because it's difficult to save these people if you are staying somewhere where bombs are coming. So on these stages, on stabilization point could be a lot kinds of help, and until our soldiers come to stabilization point, if it's became possible on evacuation transport, it's usually they are burned. Could be tourniquet conversion, could be one packing again or changing this situation. It could be venous access, pain relief, warming of the patient, and the compression of pneumothorax. And sometimes we have some cases in Ukraine when our soldiers can make a blood transplantation even on battlefield and can do this on evacuation transport. Then patient come to stabilization point. On some stabilization point, there are X-ray, mobile X-ray, so we can diagnose a lot of damages. Practically everywhere we have ultrasound systems, mobile ultrasound systems, and our doctors work on fast protocol and so we can diagnose problems with chest, with stomach, with blood in any places in body. So can be so our doctors make application of external fixation devices. It's stopping bleed. Sometimes it's final stop and bleed, so could be temporary vascular shunts. And sometimes our doctors made diagnostic laparotomy and thoracotomy. And when in Ukraine appears such step of medical aid like stabilization point, so our soldiers, so it changed saving lives of our wounded people. Then our soldiers transported to first hospitals or first line hospitals. The medical aid is more wider. If they are not very heavy patients, they could be transported to another hospitals in central Ukraine for high special medical aid, or they can be transferred to the hospitals in West Ukraine for the healing of wounds and for rehabilitation period. After recovery, some soldiers returned to duty, to service. Some resignated to non-combat support units due to health conditions, and others leave the service and became veterans. But all of them do very important work for Ukrainians because they are saving our lives. These slides present that one patient, one soldier can receive a lot of different injuries in one time, and if we plan his treatment, we usually try from hard to soft, and sometimes it could be lost a lot of months. Sometimes it could be some years, and for every patient, we should create an individual plan of treatment, but everything can be changed because could be infections, could be inflammations, could be necrosis, and a lot of another situation, complications of injury because it's high energy traumas. So some cases from hand surgery from my practice and practice of my team. I'm working in several hospitals. It's 6 hospitals. Mostly I'm working like a volunteer, and in every hospital I have a team of young, good orthopedic surgeons, and they they want to study hand surgery. it's interesting for them, it's interesting for me, so we work together. And in every hospital, I have another team. So this case from from one of this hospital, and all of my patients give permission for using their using information about them in this report. So this guy received injury in May 2024 after several months of treatment and closure of massive tissue defects with different kinds of skin grafting. There was such situation like a very hard contracture and painful fingers. He couldn't use this his hand like he wants. We understood that it's very hard injury, and I never didn't promise him that it will be like before, but we're trying to do better. So in November 24, there was a complex surgery. So it was a removal of all scars. After this, I received a very big skin defect. Arthrodesis of carpometacarpal joints by plates, arthrodesis of metacarpophalangeal joints of two fingers which are lost, long fingers. It was pin fixation, and there was a release of extensors digitorum of 4 and 5 finger, and there was a skin grafting. I used old method, but for him it was very successful. On these pictures are fixation by pins, fixation by plates. It's a result, and that is from surgery pictures. It's a skin graft from abdomen, and its result in some days. So the skin grafting was successful, and old scars which was on this hand, they was some ills, a little ill some days, and my team believed that we should remove all scars from bones. Then in some days we received such result, and there was another surgery, another step. It was stenolysis of extensors, and extensors of 4 and 5 fingers, and was the stenolysis of flexors of fourth finger, and there was a little correction of this skin graft. So that is a result in some months after therapy. So his hand looks a little cosmetically better. I hope he is satisfied, and he can move. He have some strengths. His hand. Maybe we will do something for increase function in future, but for today he is glad, so he can use his hand. Okay, next case. Next case, it's another soldier. He received trauma in 2022. He was in some hospitals in Ukraine and was in hospital in Belgium. And in August 24, he became my patient. And so I received such stories. First step, it was remove broken implants. It was steel implants, not titanium. I removed all bad tissues. all infected or dirty tissues. So then I put inside PMMA spacers and tried to make bone traction how I could, how scars let me. Then in December 24, in some months, there was another step. So it was, we create specific special implant for him. It was printed of special medical titanium on the 3D printer, and I put it inside my patient. I used bone grafting and made a reconstruction of extensor of third and second finger. And after therapy, we received such result. He come back to service to UAV unit. He is very satisfied for saving fingers, even it's that they are not the same like before trauma, and he sending me the video how he is destroying our enemy non-pilot planes. Next, it's last case for today, and it's the injury was this summer. On first steps, it was before, it was another hospital, so it was temporary fixation by pins and skin grafting graft on arterial pedicle for covering the injured skin and tissues. In 6 weeks was on his right hand was a surgery of different kinds. So it was open reduction and fixation of two metacarpal bones with plates and with bone grafting. It was practically metacarpal carpal arthrodesis. There was a tenolysis of extensors. There was a ulnar nerve release neurolysis, and there was a free skin graft for the wound on his hand. And in 3 weeks, there was surgery on another hand. It was a lot of reductions and pin grafting. It was pin fixation. It was plate fixation with bone graft, and was a correction of before skin graft. So we received such result. It's this week. Maybe on the closest day we will remove all pins. And now he is in therapy, and we are waiting for maybe not the same fashion like before trauma, but we're trying to come back him a good function. So in Ukraine, there are a lot of different kinds of hospitals. Here on the right and down, it's underground hospital, military hospital, it's stabilization point. In the center, it's my friend Igor, he is a surgeon. I asked him, can I use his photo too? It's battlefield hospital, but of first step. Here and down, it's me in usual city hospital with middle level of medical aid. Here is a city hospital with higher level of medical aid. In left down, it's one of the hospital of the highest level with good equipment. And among of these, there are some hospital like right up. It's just small hospitals in Ukraine where still our patient receive treatment, military patient or civilian patient. And then thank you for attention. In Ukraine, our medicine is trying to help to all people, for civilian and for military people. And sometimes often to give a good treatment for injured people, we need in a lot of medication, a lot of equipment, a lot of implants and medical stuff. So mostly a lot of charity foundation trying to help to injured people, and we do it good, even if it's difficult. And this foundation, it's a foundation in memory of my mom. She was killed in Bucha, and in 2022. And this foundation is helping to wounded soldiers and to civilian people to come back to healthy life. That's all. Thank you for attention.
Thank you so much. Those outcomes were incredible. It was very impressive. Thank you. Our next speaker is Dr. Miguel Perella Cruz, and he's going to share with us the essential elements for a successful humanitarian mission.
All right, well, let me just get geared up over here. And we'll get going here. Okay, can you see my slides? Okay, good. Hello, everyone. Can you see me?
Yes, we see you.
Okay, all right, well, hello, everyone, and thank you, Harvey and ASSH for the invitation to share some of my thoughts. I had the opportunity to serve in the military for 35 years. And as part of my duties in the military, I was part of the international health team. And I was able to actually visit numerous countries and participate in various medical missions around the world. So some of my most significant experiences of my career have been the moments that I spent immersing myself in cultures, engaging with local populations, and I spent a considerable amount of time actually just doing this. And this has been some of my best experiences. I must say I have no conflict of interest for this presentation. Okay. And here you can just see some of the photos of some of the places that I've been to, but I've also been to other places as well. So what I'd like to do during this quick presentation is just go over what I consider to be 11 essential steps for anyone that may be thinking about performing one of these medical missions if you're trying to organize it. So something that that we worked through, and it's really hard getting some of these missions off the ground. So first of all, researching the location where the health needs, to understand the health needs of the given population that you're going to serve is very, very important. So when we do this, before we even start out with the mission, we like to collaborate with the local health authorities that are present, the organizations, and try to identify some of the most pressing medical issues that are within the scope of the mission and the team that we're working with. So we clearly like to outline and articulate the mission goals. such as improving health access to healthcare, providing emergency medical services, or focusing in on specific healthcare issues, such as pediatric hand conditions with acute and chronic problems. And we'd like to really make sure that all the parties understand exactly what's going on and what we're trying to accomplish. The third thing is actually we like to try to build some partnerships with the local healthcare providers, the NGOs, and the community leaders. This really helps to ensure cultural sensitivity and increases the mission's effectiveness. So this is a very important step, and the PR aspect of the mission should not be overlooked. So with that in place, we would like to assemble a diverse team of healthcare professionals, including doctors, nurses, support staff, along with logistical and administrative personnel to help us. And it is very important, again, to make sure that people are trained prior to going with cultural competencies and customs. The logistics is extremely important. That can make or break one of these missions. So we need to plan for transportation, accommodation, supplies, and equipment. We also have to have a plan in place in the event that someone gets ill or injured. You have to have an evacuation plan for your members and make sure you have that in place. So that it is important to ensure that you have reliable supply, medical supply, medications, and there's some interesting stories behind that one, and any emergencies that may arise. So we like to familiarize ourselves, we need to, with legal requirements when you go into another country, including the necessary visas and permits. And again, as I mentioned, you need to adhere to ethical guidelines respecting the local customs and practices. The training for your team on specific health issues that you're going to encounter is important. To try to get as much training beforehand so that to really know what we're up against and try to make some preparations for what's to come. It's also good if we can also try to help them along with some of the language, if possible, some of the basics, so they have a little understanding of what's going on when they encounter patients. So we like to focus on building local capacity. Let me just go back one, I think, right there. Building a local capacity by training the local healthcare workers, ensuring that the interventions are sustainable long after the mission ends. So this is really the ultimate goal is basically just to make sure that you can train some of the local care providers and that they can actually get your knowledge and pass it on. So with this said, we can also try to establish some metrics to evaluate the impact of your mission, collect the data and healthcare outcomes, and try to get some feedback from the community and learn so you can improve any future missions that may come. And we like to try to generate some after action reports for others to learn from. The good, the bad, and the ugly are important to document. Okay, so we covered this already. Let me just go back. That is sync here. And we talked about the metrics already. That is important to collect the data and really have a good record. At first, when we would do some of these missions, we didn't have that, but we always try to generate some kind of after-action report so we can pass it on to the next group, and that really helped us tremendously. Be surprised some of the particular nuances of a given area. The relationships are extremely important, the local partners that you develop, and a lot of these partnerships actually are lifelong partnerships and really help to build bonds. And again, as I talked about the outcomes and planning future missions. So now the fundraising for some of these, which are all volunteer, I've done also not only military, but also some civilian missions as well. So you have to have money in order to try to do and accomplish your goals. So we have fundraising, we have grants, we have donations, partnerships, and you have to be very transparent with the funds. We have reports, and we generate all this in the reports that we do. So there's no question about what we're doing and where the funds are going. Now, what I'd like to do is kind of just give you this little short video of the Guatemala project, which actually involved several organizations. It involved the Hand Societies, Touching Hand. It started out actually from the association, from the Vargas grant. I went with one of the hand therapists to Guatemala, and after being there and after the mission, they told me, they said, "You're not just going to be here for 1 year, are you?" So the intent was for 1 year, but we developed and we started a nonprofit foundation, and then the Shriners came in with Dr. Kozin and really developed this into a good project. And it's nice when you go to one place over and over again, because you can really build on what you need and see the problems and try to address the problems that you can. So this mission has been going on for over 25 years. So I'll let you just show you this quick video on it.
Hi, I am Lynn Bassini, founder of the Guatemala Healing Hands Foundation and hand therapist for over 45 years. Brought up in Guatemala, I am proud to lead an organization as we mark 2 decades of essential hand and upper extremity medical care for children in need. This year alone, with the help of 42 incredible volunteers, we screened 136 children and carried out 61 procedures at the Shalom Foundation's Moore Pediatric Surgery Center in Guatemala City. These kids, some traveling for days to reach us, received not just surgery, but a commitment to ongoing care. Our comprehensive screening process ensures every child receives the best possible care. Our team's preparation and teamwork are key to our mission success. We bring carefully selected and approved equipment, ensuring the highest standards of care. Each mission, we identify one child we cannot treat in Guatemala and bring to the United States to ensure no child is left behind. Thanks to Dr. Kozin, Shriners Hospital, and other partners who come together to make this happen. Beyond the operating rooms, we build lasting bonds and celebrate our shared mission. These kids are followed up by our local doctors and by us upon our return mission, ensuring continuity in care. We don't just operate and leave. We improve the quality of a child's life through surgery and therapy, impacting their family's outlook, allowing them to focus on their lives as a family. Together, we are changing lives one hand at a time. Thank you so much for your time and your support.
Anyway, these are some of the things that I've actually encountered throughout my, that I've put together. And I think that it's kind of basic, but nevertheless, I think it's important to actually follow these steps. Thank you very much. That's all I have.
Thank you, Miguel. And I really liked the sustainability aspect of it. I think it's so important to do more than just sweep in and leave. So I really enjoyed that. Our next
Very
speaker is
important.
Julie West. Oh, did you want to say something?
I was just going to say that's very important. That's the ultimate goal, is basically just to not only go there and treat the patients, but also pass on your knowledge and actually help themselves. So that's really the ultimate goal of these missions. Thank you.
So our next speaker is Julie West. She's a PA from Ohio, and she's traveled on a number of surgical missions. And she's going to talk to us about some of the challenges that PAs face in developing countries.
All right. Good morning. Can you guys see me in my slides? Hopefully. Well, thank you so much to AAHS for this opportunity and for including Advanced Practice Provider in this presentation. Oof, my slides are not advancing, are they? Okay. I have nothing to disclose. So I work at Ohio State alongside two surgeons, Amy Moore and Jason Souza. And we work in an environment, I wanted to set the stage and as to what kind of environment I work in and what kind of mission trips I've been involved in. So I work in complex nerve, upper and lower extremity, and I realized that I'm part of a subspecialized team in extremity reconstruction. But I think working in this subspecialized area, there's a need in the international community. And though these incredible surgeons can go and help teach the surgeons, I think bringing a team and really expanding their care is the role that I've been able to provide as an advanced practice provider on these trips. I've been fortunate to travel to Bolivia a number of times, to Italy, and to Israel. And each has been an incredible experience, personally, professionally, and I feel really lucky to have been part of that. So my first trip was to Bolivia coming out of COVID, and I sort of felt like this on day one. Who am I? What is my role? How do I fit in? I went with the surgeon I work with regularly, but the country I'd been in doesn't have advanced practice providers. The organization we went with had never taken an advanced practice provider. And the surgeon I worked with had never been on a trip herself. And so, I think it was a real wake-up call to me as to how do I explain myself in the international community. In the US and to some extent in Canada, the UK, and Australia, advanced practice providers are called different names, but exist, sort of. I don't know that it's exactly the role that we play in the US, but the concept is familiar. But upon arrival in Bolivia in 2022, we were masked. I didn't speak the language, and it was apparent that they were not familiar with the role I could provide. So I really had to take a step back and think, like, how am I going to get through this week, and what can I do? And so I think I broke it down as to, it might not be the title, but it's the competency and the care that I can provide. And so for those of you that are on this call that are in the international community and are probably wondering, what am I talking about, or what is my role? In the US, advanced practice providers are defined as nurse practitioners and physician assistants. And we really, especially in surgical specialties, expand the care of the surgeon or the practice that we work with. And so that's, I think, what my role was on, what my role has been, will be on all of these mission trips. We can independently see and evaluate patients. PAs and some nurse practitioners can help assist in the OR. And then we can, collaborate with, many members of the medical team, from students to residents to therapists. And that's the role that I provided. It was really an extension of the surgeon I work with, and what we were there to do. In the clinic, especially in Bolivia, there was such a high volume of patients. There were calls out for, there's a surgeon coming in, nerve injuries, nerve pain. And so we had lines down the hall of patients. And so it really was a great thing I was there, because we could divide the patient assessment. And then we had a tremendous list of patients each time that we've had to, decide who's going to get cared for that week. The same thing was in Israel, just the volume of patients, and then, how can we most maximize our time? What do the surgeons that were there to help educate really want to learn? In the OR, the same thing. Nerve surgery in a third world country wasn't ever done before. And so the picture on the left is me with the two scrub nurses that handled both ORs all week, and trying to say, this is what we're going to need, how we're going to set things up. I think the communication via translator and my limited language capabilities became very important, and making sure that I was in the OR. The surgeon I worked with was working with the local surgeon, and they were kind of talking about the procedure and what they were doing. And I think I was kind of doing everything else to try and make sure that everything went well in the case. We spent time with medical students. We had a whole slew of students, residents, and other physicians in the room. And I think, a role I can take step back is to make sure that I'm mentoring everybody as good as well as possible. And then follow up, like our other speakers said, it's not just going there and doing what we can in the week. It's how do we make this a sustainable endeavor? And so the first time we were there, I was, again, unprepared for a lot of things. But so those are our translated written discharge instructions and therapy protocol. When we went back, I formalized it and brought materials and printed out many copies that the patients, the therapists, the students, the residents, the physicians could have, so that they can, especially for what we were going for nerve reconstruction. I mean, it's not an immediate result. It takes months, a year even to really realize the benefit of doing that type of surgery. And so we couldn't just leave and be done. We've done telehealth follow-ups with the surgeon, with the patients, and fortunately, to Bolivia, we've been back a couple of times, so we've been able to see those patients back on an annual basis to really make sure that they've done what they need to. They understand the type of rehab we need them to do. And so I just want to say thank you. Resurge International is who I've traveled with to Bolivia a few times. The surgeons that I work with, I'm really fortunate to have had these opportunities, and I hope that they occur in the future. I think having an advanced practice provider as part of the team, again, it may not be a recognized profession in other parts of the world, but I think that we can bring a lot to the table on these trips to expand the mission in a lot of ways. And so I think if you can take one thing from this presentation, it would be that we're an expansion of the team that we work with, and we have incredible expertise in those fields. Thank you.
Thanks, Julie. That was really interesting. Our final speaker is Debbie Gray. She's a hand therapist from South Africa, and she's now based in the UK. And Debbie has been everywhere and in conflict zones. She just spent, 3 months on the front line in Ukraine, and she's also been to Gaza. So exciting to hear her speak, and appreciate you coming, Debbie.
Thank you. Good morning, good afternoon, and good evening, everyone, depending on where in the world you are joining from. It's a real privilege to be a part of this webinar today. It's a big topic to cover in a very limited time, but I hope what I share will offer some helpful insights and reflections. So since training and starting my working career in South Africa, I've worked in NHS hospitals in the UK. And during the past 20 or so years here, I've taken both short and extended breaks to work in more resource-constrained and conflict-affected settings around the world, including Rwanda, Togo on the Mercy ship, Nepal in the Civil War, and then post-earthquake, Gaza post-2014 airstrikes, and then most recently, Ukraine since 2022, which I'll be focusing on covering a few key areas given the time limit. And the screen's not, sorry, let's see. It's not moving now. Oh, there we go. Okay, so I'm sharing these principles not because I've mastered them, not at all, but because I'm still learning, especially from what hasn't gone so well over the past 25 years in challenging contexts. So working in unfamiliar systems is never straightforward. Rapid deployments often mean arriving before fully understanding how local healthcare systems work. And so every context, as we know, is different. And there's no one-size-fits-all model. That's why listening first with humility and observation is so important. It's how trust begins. But trust takes time. Short deployments really allow us space to build it. We arrive, we offer, and we leave. But sustainable collaboration requires continuity, listening, and shared ownership. Interventions must fit into existing systems. We can't expect those systems to change overnight, especially in disaster or conflict-affected areas where complexity runs deep. War adds additional layers of challenge for everyone, and local teams face relentless pressure, limited resources, and constantly evolving systems. In places like Ukraine, it's really possible to implement rehab protocols or interventions based solely on your own model of best practice. So I found that it's been through the repeated visits that I've begun to understand the rehab landscape there. And even now, I know I still have so much to learn. So we focus on what's safe, achievable, and sustainable. And above all, we empower the local teams. They're the true experts. Supporting trainer of trainer model helps that growth as we continue. That growth continue long after we leave. So, over the past few years, my role in Ukraine is focused on capacity building with rehab teams, particularly in the acute care settings. The clinical focus has included burns, fractures, peripheral nerve injuries, tendons injuries, splinting, and positioning. I've also been fortunate enough to collaborate with Nicola Goldsmith and Nathan Shorts and the Hand in Hand with Ukraine project, grateful for the support of the AHTF grants toward the website development and supplies. So in Ukraine, as Dr. Oksana has so helpfully highlighted, the healthcare system, including rehabilitation, is under extraordinary strain, and rehab teams face high injury volumes and complex polytrauma. So often, they're expected to manage diverse cases and rapidly become multi-specialists. So staffing shortages are critical, especially I've seen in acute settings like burns ICUs, where you might have one or two nurses that cover, say, 10 beds. Referral pathways and documentation are often fragmented, and rehab units may be disconnected from the surgical hospitals, or the hospitals where the patients have received their surgery, leaving therapists without essential clinical history or post-op documentation and guidance, disrupting the continuity of care. And then there's the therapy professions like OT and physio are still developing. So professional bodies were only established in the past 5 or so years. And most therapists have trained through all the diploma programs, and a few have accessed the new master's level curriculum designed to bridge the foundational gaps in knowledge, which is covering the anatomy, physiology, and evidence-based clinical reasoning. So for this reason, the surgeons typically oversee the acute rehab with little MDT involvement, and may be reluctant to share oversight due to perceptions of therapist training. And hand therapy remains a new and evolving concept. Rehab services are funded by the Ministry of Health, supporting a short, intensive 2-week block in the subacute phase. And this modeling excludes the first 4, 6 or plus weeks post-injury. And so, which is poorly suited to the complex war-related injuries like tendon, nerve, burns, and fractures, as mentioned. And as can be expected, then the delays in targeted rehab interventions significantly increase the risk of the contractures and complications. And so physician of rehab medicine doctors are often neurologists, and they oversee leading the rehab teams, but broader MDT collaboration is still very much emerging. Soldiers, as Dr. Oksana has already mentioned, return to the front line, and sometimes very soon, and sometimes with accumulative injuries. So looking at the collaboration part for better outcomes, one of the most rewarding parts of my work in Ukraine over the past few years has been supporting colleagues with practical tools they can use in complex rehab settings, tools they can draw from as they navigate challenging cases. It's never about arriving with all the answers, but co-creating solutions that fit their context. Trust with traumatologists and hand surgeons is growing. Slowly but surely, the rehab role is being clarified for early inclusion. And hand therapy protocols introduced through targeted capacity building with designated MDTs. Therapists continue to show remarkable resilience, finding creative ways to contribute in acute care, despite the funding gaps. We've worked together in trying to solve the puzzle of each patient's recovery, aiming for pain-free functional outcomes. I've signposted resources to support patient education, for example, like Nicola Goldsmith's website, and I'm helping my burns rehab team, one of the rehab teams, develop patient advice and exercise sheets and educational videos for national access via Burns Rehab Network we are trying to launch. And these materials are shaped with the local therapist, not handed over. We've also co-developed referral forms and assessment tools to improve therapy planning and surgeon-therapist communication. And much of this happens through bedside training, implementing hand rehab protocols, developing adaptable exercise sheets, and focusing on contracture prevention from day one, which is critical given delays and complexity. And just a few case reflections I'd like to share, which highlight how trust and teamwork can transform rehab in acute settings. So the first case was when I was working with the rehab team at a major trauma hospital. A trauma surgeon who had international experience approached me, introducing me to a motivated master's level physio in training. The surgeons had already begun mentoring her in theatre, and I was invited to support and guide her and guide early rehab planning. So as a team, we reviewed protocols and began treatment within the first week of a complex post-op case, improvising with the kettle at the patient's bedside to fabricate a splint, and continued to work in close collaboration with the surgeons week by week, by which time I did so remotely. The patient's recovery is strong, and the surgeon and physio team later presented their work at the Hand in Hand with Ukraine in partnership with WHO Intense Hand Therapy Training Week, showing other hospital rehab teams what MDT integration can look like in practice. I then presented this with a physio at the second National Physio Congress in Ukraine. And the second case was in Eastern Ukraine. I worked with a very humble chief hand surgeon. I introduced him to post-op protocol guidelines. He approached me to trial early rehab for a post-op flexor tendons repair case. We translated the protocols, educated the patient daily, and built strong team understanding. But when the patient was suddenly summoned back to report to his military commission in another part of the country a week after commencing rehab, we equipped him with a printed guidance and a lot of role play prep for the graded steps in the home program progression for the weeks ahead to support continuity. It was so drilled into him that I had the patients, all military, in the same ward bay, overseeing his exercise regime and giving the reports of how the patient had been carrying out his exercises. And a third case as well, based on one of the burns units, I crossed paths with a visiting team of hand surgeons from abroad who were operating on a 20-year-old soldier who'd already undergone multiple surgeries on his arm, severely injured in a blast. And when they learned I was a hand therapist, they introduced me to one of the doctors there, a wonderful young surgeon specializing in hands based in the trauma unit who welcomed the team approach. We worked together on post-op rehab, and I invited some therapists I'd been mentoring to join us. And thankfully, the patient progressed well. And from that collaboration, I was invited by the wider team of upper limb trauma surgeons to introduce early rehab guidelines and protocols. That invitation meant a lot. It wasn't just about the presentation, it was about the trust we'd built. The door had been opened and we'd earned the understanding needed to walk through it together. And lastly, I wanted to share a case from another burns unit where collaboration didn't come easily at first. The reconstructive surgeon is a great surgeon, but he was hesitant to work with the rehab team, especially around introducing early post-op rehab. It took 3 months of consistent evidence-based support and practical demonstration to begin shifting that dynamic. And by working alongside therapists and showing results with a few patients, we gradually earned his trust. And eventually he allowed us to begin seeing patients more acutely. I appointed one therapist who had shown rapid growth and deep interest to lead the interaction with him and oversee the safe rehab care under his guidance. And we began meeting as a small team to discuss how MDT working could move forward. It was a slow but meaningful shift, and one built on trust, shared outcomes, and respectful collaboration. And then lastly, I want to pause here and share some personal reflections. Working in Ukraine, I've witnessed military patients returning to the front line, and ambulance buses arriving full directly from it. The recent choice of donated supplies often carry their own complexities. Air alarms, drones, and explosions are part of the backdrop. But what stays with me most is the quiet resilience of local colleagues. Many are facing immense personal strain, be it loved ones on the front line and occupied regions, grief, uncertainty, burnout, and displaced living. And yet they continue to show up, to care, to teach, and to lead. Their strength humbles me, it inspires me every day. Thank you.
Wow, that was amazing. All of you were amazing, and the world's a better place because you're in it. So thank you so much. I don't see any questions in the chat right now. Does anyone have any questions?
Well, I have a question. Oksana, thank you so much for sharing your experiences. I guess for the rest of us, I'd love to hear maybe you could summarize what lessons you have learned working in Ukraine and, and serving soldiers wounded in the war recently. What are the biggest lessons you impart to the rest of us that you have learned working in a war-torn environment in managing these patients?
In our war in Ukraine, which is a hard war last 3.5 years, our Ukrainian people, in the beginning full-scale invasion, start to work like volunteers, practically everyone in Ukraine. All medical persons and not medical, and everyone trying to help to soldiers, try to help to people, to refugees people, because a lot of them in Ukraine and go from Ukraine and go away from Ukraine because the war come to their homes. And when a lot of people wants to help each other, wants to help wounded people, our life became better, and destinies of our soldiers could be better than without this help. The harder thing is we have too much injured people. We have more than 100,000 people with amputee in Ukraine just for these days. We have more, I think, among 1 million injured people, and these injuries, these war injuries, they are very hard, and they need in a long time of treatment and need a lot of medication and another medical stuff for recovering. Unfortunately, in this war, Ukrainian medicine is developing, unfortunately. But it's developing in a military way, not in civil way, not in prophylaxis of diseases. And we still need help. Sometimes all doctors, all medical, all medics, all medical specialists, we now have a lot of practice. Sometimes I think it's too much for us, for every surgeon in this life. But all of us, we know that we should help. we should treat our soldiers. We should treat civilian people who had injuries, and we will do it until the end of war and long years after. And for me, like a person, I hate war because a lot of people как бы страдают и suffer. So that's why I want that it's finished, but I want that Ukrainian will win.
Well, yes.
I can, again, here, let me just, I can just say a little bit about what I've learned from my experience in Afghanistan. And I think one important aspect was that try to not have real unrealistic expectations when you talk to the patients, and tell them clearly what you seek to accomplish. I think you don't want to, disappoint them. So that was one lesson that I really learned. Just make sure you clearly define what your goals are and relate that to the individuals. And I think that was, especially in a war zone, which you have limited resources and capabilities.
I really appreciate Miguel. I really appreciate that, Miguel, for you sharing your experiences. And thank you so much, Oksana, for sharing your experiences as well. So we are running a little bit over. So, again, I'd like to thank our panelists for really excellent talks. I'd like to thank Mary for moderating this really excellent webinar. And I hope that you as the audience learned some new pearls as well. I definitely learned a lot from this webinar. So just as a reminder, this webinar will be recorded on the AHS website, handsurgery.org, and should be available for viewing in the near future. Please keep a watch out for future webinars. We do release this on a monthly schedule from the AHS, and this will be available on the AHS website through announcements as well as through emails. So again, thank you very much, everybody, for joining us. Thank you, our panelists, for excellent talks, and have a great day ahead. Thank you, everybody. Bye-bye.
Goodbye.
Good night. Bye.